Good afternoon, and welcome to The Wounded Warrior, Caring for the Invisible Wounds of War. I'm Julie Miller, Editor-in-Chief of Addiction Professional. Today's program is sponsored by Sierra Tucson. Thank you to our sponsor and to all of you in our audience for taking the time to join us today. Before we get started, let's review our housekeeping notes. To submit a question or a technical issue, please use the Q&A area below the slides at any time. You don't have to wait until the end of the program to ask our presenter a question. To download a copy of the presentation, please click on the link in the Resources tab to the right of your slides. And a special note about CE credit. To get your CE credit, you must watch the program all the way through until the Q&A section at the end of the presentation. At the end, please do not leave the web page. This site will automatically redirect you to a survey. This survey must be completed in order to generate your CE certificate. For those of you watching in a group, please download the group submission guide, which is in the Resources tab, and follow the instructions provided. Please note that CE credit is not available for the archived webinar. It is only available for the live event today. And finally, for those of you who tweet, please tweet along with us using the hashtag #APLiveWebinar. At this time, it's my pleasure to introduce our speaker, Bill Reynolds. Bill is a U.S. Navy trained physician assistant and served on active duty for 30 years, retiring as a lieutenant commander in 2012. He has psychiatry and addiction medicine experience in addition to his family medicine background. Bill works with trauma survivors, including Marines and sailors adversely affected by wartime stress. Bill, thanks so much for taking the time to speak with us today. With that, I'll turn the audience over to you.
Okay, thank you, Julie. Well, welcome everybody. Thank you for that introduction, and thanks to everybody that signed up for the webinar today. And we were talking a few months ago, and we thought that it would be, with Veterans Day coming up within the next 2 months, we thought it would be a timely piece to talk about the wounded warrior and some of the special challenges that they face. And we recently had the anniversary of 9/11 a couple days ago, and it reminded me that everything has changed since 9/11, certainly with the military. It's affected all of us, I'm sure, to some degree. But, it's been 16 years, and the military operations have been pretty nonstop. When you look back at World War II, that was 4 to 5 years, and, this has gone on and on. So we're in our 16th year. We're starting to actually send more people back to Afghanistan, as I understand it, and there's really, with the global war on terror, it's an ongoing thing. And just to give you a quick snapshot about the number of battle deaths, if you look back to World War II, there was almost 300,000 people that were killed during World War II. Now, as far as Iraq goes, the number of people that have died in hostile deaths is around 3,500. And non-hostile deaths is around 930. So that's a total of 4,400 people. And when you compare the numbers to World War II, that's obviously there's no comparison. But what we do have these days is we have a lot more people surviving. So as they come back home, they need ongoing care, often through the VA, and many people seek treatment through the civilian community as well. So anyways, what I'm going to do is, first of all, go ahead and start. We're going to talk a little bit about the history of PTSD. We could do the next slide, please. Okay, there we go. Okay, so PTSD, by the way, PTSD, if you can go back one slide, please. There's a lot of people that work in the recovery community that don't like the term disorder, and I'm among them, so what I'm going to do is just refer to it as PTS, which is post-traumatic stress. That is nothing new. It's been around, time immemorial. The earliest reference that I could find to that was actually by an Austrian physician back in the 1700s, and he coined the term nostalgia, where people coming back from battle often, suffering severe physical and emotional wounds, wanted to be back on the front lines. They wanted to be back with their friends despite the, severity of the injuries that they had. So, Civil War, the same thing. They called it soldier's heart. And then if you look at World War II or World War I, the term shell shock came into use. And the reason for that is during World War I, there was a lot of artillery that was utilized. Big guns, and it was originally hypothesized that people who developed PTS symptoms were actually exposed to concussive blasts. There was actually a gentleman, Dr. Richard Myers, who, he started examining the people coming back from the front lines, and many of them suffered from uncontrollable diarrhea. Some people had facial tics, people that perhaps had bayoneted men in the face. They mimicked symptoms that, from injuries that they had inflicted on other people. It was also called compensation neurosis and fright neurosis. But as time went on and they started having PTS servicemen come back who had not been exposed to concussive blasts, that kind of shot that theory down. So it's interesting because the thought was at that time it then shifted from a mechanical injury to the fact that these people were weak and they were cowards, and so it really turned into a big shaming event. World War II, we called it battle fatigue. Vietnam, as you can see there, post-Vietnam syndrome. Actually, from what I understand, a lot of the Vietnam vets did not like that term, and they actually were amongst the first servicemen who really actively advocated for themselves to be recognized, their wartime experiences to be recognized. And, there were marches held in New York City in the late 60s, and this went on. But it wasn't until 1980 that PTSD was formally recognized by the DSM-3. Next slide, please. She's got it. Okay, I just wanted to share this picture with you. This is back during World War I, and this is actually a contraption that one of the British surgeons came up with. And to treat the shell shock, they actually administered electric shocks to people. Sometimes they actually put cigarettes out on people's tongues and threw cold water in their face, anything to get people to kind of open up and talk. So they gave one instance actually that I read about, that after essentially torturing one guy for several hours, he was able to gasp, "I want a drink of water," and the doctor in charge of that considered that to be curative, that he was actually able to speak. He's probably suffering from a conversion disorder. So anyways, the point is we have come a long ways in treating PTSD, and we certainly don't have to do that anymore. Okay, next slide, please. Okay, so we know that the DSM-5 made some changes with the diagnostic criteria. Now, if you look at the DSM-5, there's criterion A through H, and if you go through, there has to be wickets met, either 1 or 2, depending upon the criterion. One of the things that you may ask, what's different about the DSM-5 is, as compared to the DSM-4, is they removed there was a criteria of a traumatic event, such as the unexpected death of a family due to natural causes, is no longer included. So, and they also removed another criteria that the response to a traumatic event had to involve intense fear, hopelessness, and horror. They just found that, those things didn't really improve diagnostic accuracy. And, you can read through the symptoms here. Obviously, this can also affect our civilian, people that aren't in the military, trauma symptoms as well. One thing that's not listed on there that is a really, really big thing with post-traumatic stress is sleep disturbance. There's greater than 90% of the vets that do have PTS that suffer from sleep disturbance. So, and we know that the gold standard for sleep disturbances is not medication, it's actually CBT, although some medications are okay in the short term. And there's often underlying physical things that have to be ruled out as well, such as sleep apnea and whatnot. Okay, next slide, please. So again, we have the symptoms. Here's some more of the criteria. You guys can certainly read through that. The two specifications they have with the DSM-5 is they have now what is called the dissociative specification. So some people experience depersonalization, which is described as, oftentimes people feel they have a sense that they're floating outside their body, or they just sort of feel detached. Or they can also have derealization, which many clients describe as kind of a distortion, as if, things aren't real, or it's just feel out of it. And then, of course, there's another specification, the delayed specification, for people that develop symptoms. Really cannot fully diagnose somebody with PTS until at least 6 months after the trauma, although they may have symptoms that occur initially. So anyways, those are the criteria, and I'm sure that everybody's up to speed on that. Next slide, please. So when we talk about just a little more about the difference between the immediate and the delayed onset, usually most people develop symptoms within the first 3 months. But, there's often people that actually, I've seen more than a few people that haven't started to develop symptoms for several years. If you think about some of the World War II vets and the Korean vets, this is something that they didn't really talk about. There was actually a book called Flags of Our Fathers that some of you may have read, but it was written by the son of one of the guys that was on Iwo Jima, that infamous picture planting the flag on Mount Suribachi. Well, the guy that wrote this book did not know that his father was one of those people. He was actually a Navy corpsman until after his dad died away. So there's really a lot of people that have suffered in silence for a really, really long time. So again, it doesn't have to be within the first 3 months, although most of the times it is. So immediate onset, we know that the sooner somebody seeks treatment, we're going to be able to get in there and use those interventions right away, and they do have a better prognosis per the studies in the long term. So a lot of times symptoms are resolved within 6 months, but we know that sometimes they can linger for years. Everybody's different, right? The delayed onset, they're a little bit tougher to treat. They're the ones that are more likely to become chronic, and these are the people that have repressed memories, where the intensity of the conflict was so horrific that they just don't have memories of it. So again, and we know that depression, after somebody experiences a traumatic event, depression can certainly occur, anxiety can certainly occur, but the difference is depression and anxiety doesn't necessarily include the intrusive thoughts or the hyperarousal. So that's really the key with PTS symptomatology. Next slide, please. Okay, so there is something in the military that a term, this is called a combat operational stress reaction. You're not going to find this in the DSM anywhere. It's not even, it's not an ICD-9 code. This is a military term. And the reason that, the military, we came up with that is because there are so many people that are stigmatized by wanting to seek treatment, but they're afraid that it's going to get in their medical record and they're going to be, labeled as a loser, or they're not going to promote whatever. So for people out on the battlefield that do develop acute symptoms that last for 72 hours or less, this is the term that we use, the combat operational stress reaction. So again, it's independent of a formal diagnosis. The goal is to, again, destigmatize it and to make sure that we want to encourage people to come seek treatment. And you can read the clinical manifestations there. It can certainly be physiologic, mental, emotional, or behavioral. Oftentimes people will, it'll be manifested by, just fatigue, and they're not performing up to par. They become reckless in their duties or whatever. One of the acronyms that we use in the military, the whole kind of goal with the combat operational stress reaction is BICEPS, and that's how we like to manage things. So BICEPS, the B stands for brevity. That means that the treatment period is typically, it's going to last for 1 to 3 days. The I is for immediacy, and that means that we want to get in and we want to intervene as soon as possible. The C stands for contact, and what that means is we really want to emphasize the service member still being a part of his unit, and he's still a part of the team. Just because he's temporarily out of out of the game doesn't mean that, he's not a part of the unit. The E is expectancy, and that means that we normalize their response. It's like, okay, you're having an abnormal reaction or a normal reaction to an abnormal event, and the expectation is that they're going to return back to duty as soon as possible. We're not planting thoughts in their head about being medevaced home or anything. The P stands for proximity, and this is key. We want to keep the service members as close to their unit as possible. If they do come back to a battalion aid station, we want to keep them separate from the medical patients. We don't want to put them in that sick role at all. And the S in biceps stands for simplicity, and that's just the old acronym KISS. Keep it simple, silly, right? So we want to just take care of their hydration, give them some good nutrition, and just encourage them to get back to the fight as soon as they can. There's something on the slide there that talks about combat stress, positive or negative. Positive combat stress, one of the big things that people describe with being in combat together is they may be going through hell, but they're going through hell with their friends. They're going through hell with their comrades. So positive combat stress is increased bonding. It's increased camaraderie. You all have that shared experience. Hopefully, you have increased confidence in your buddies and your own abilities. Negative combat response obviously can result in maladaptive behaviors. So, and just for your own information, when people get ready to go on a deployment, it's typically broken up into, there's kind of phases of a deployment, right? So when you get orders to deploy, the initial deployment, it's pretty fast paced. You're getting ready to go. You're either flying overseas or you're taking a ship over there. You got to make sure all your gear's there. Anxiety goes up, especially for a lot of the guys that have not been in combat before. Mid-deployment, once you get over there and somewhat settled in, that's when people have a tendency to kind of worry about their families, what's going on back home. And the final phase of the deployment, if there's one thing that somebody looks forward to when they deploy, it's that return home date. People fixate on that. And if there's any delay in leaving the combat theater, that has a tendency to really increase stress. And this is the time where you start hearing lots and lots of rumors. Oh, I heard we're going to be delayed for a week or for 2 weeks, and it's just total guessing. So, and the final phase of the deployment is homecoming, and that's where you come back home. You have family readjustment. You may grieve, you may loss, or the grief and loss you may have experienced. Maybe one of your friends got wounded over there, or got killed, unfortunately. Okay, next slide, please. Okay, I'm gonna get my geek on here, so to speak. This is really interesting stuff when you talk about the neurobiology of PTSD. Many of you may be familiar with Dr. Stephen Porges. He wrote the book, The Polyvagal Theory, groundbreaking research showing that there's a direct link between trauma and people that have dysregulated nervous systems, right? So we do know that after any kind of trauma, whether it's in combat, a natural disaster, domestic violence, sexual assault, the brain and the body change. There are physiologic changes. Every cell records memories, and every trauma-related neural pathway has the opportunity to repeatedly reactivate. So even though we were talking about the repressed memories earlier, that pathway, if the nervous system dysregulation is not dealt with, that's where people get triggered, when they have those neural pathways that are reactivated. There's a gentleman, Dr. Paul MacLean. He came up with the triune brain model. I believe that's how you pronounce it. But we talk about the different parts of the brain here, right? So the reptilian brain is also known as the brain stem. This is the part of the brain, this is what keeps us alive. This is what, keeps us on alert, survival instincts, and this is what controls really the sympathetic and the parasympathetic nervous system. You go to the next part of the brain is the mammalian or the limbic or the midbrain. This is the part of the brain that processes emotions. And then, of course, the cortex. We know that's the most highly evolved part of the brain, and this is where we make decisions. This is where we learn. This is where we store memories, and this keeps us in check with inhibitory functions, right? So whenever somebody experiences a trauma, the part of the brain that takes control is that reptilian brain. That is what actually shifts our body into the reactive mode. So that's where we go into the fight, flight, or freeze mode. It shuts down all non-essential body and mind processes, and the brainstem is really what orchestrates our survival mode. This is what's kicking in if if we're being chased by a tiger down the street, or you're running from live fire. Okay, so the sympathetic nervous system takes over. We get increased stress hormones, and that's where we fight, we flee, or we freeze. Typically, when that trauma goes away, that's when the parasympathetic nervous system takes over, and that's where we go back into restorative mode. So this is where the stress hormones are decreased, and this allows the brain to shift back into the kind of the normal mode. So, I think it's around 20% of trauma survivors that go on to develop PTSD. Many people remain in that hyperarousal mode, right? So you may not be physically out of breath or sweating, but your body, there's still that dysregulated nervous system that keeps you in that chronic state of hyperarousal. And those people can often, they actually present as feeling numb, kind of detached. I can't relate to other people. One other thing I just want to mention real quick is, the amygdala. That's a little almond-shaped part of our brain, deep in the brain, and that's also responsible for survival threat identification. And, in a trauma, the amygdala gets caught up in a very highly activated loop, and it perceives threats everywhere. That's why you hear about some vets that are coming back from combat, and they're driving down the road and they see a piece of trash. Many people are triggered because over in Iraq and Afghanistan, the most innocuous piece of trash can be an IED, which is an improvised explosive device. So, anyways, so the good news is, with time and appropriate therapies, we can actually change these in the brain. Treating somebody for trauma, they are not going to get better unless the dysregulation of the nervous system is addressed. And I'll say that again, treating trauma is not going to be successful until it's identified and the nervous system is appropriately regulated. We multiple types of therapies to help kind of get our service members and our patients out of that state of hyperarousal. Some people respond well to treatment, within a relatively short time, and some people don't. So again, it's highly individualized. Okay, next slide, please. Okay, just going to talk a little bit about prevalence. American adults, it's 7.8% of people in the general, the civilian community experience post-traumatic stress, twice as common in men. We know that it's twice as common in women. It's twice as common in women than men. Women, we know, are far more, they're subject to rape, molestation, childhood physical abuse, child sexual abuse, physical attacks, and being threatened, oftentimes with a weapon. For men, the most common PTSDs are actually combat exposure and childhood neglect, and again, the same thing, childhood physical abuse. It would be interesting to see a study of people that have been diagnosed with PTS in the military that already had pre-existing trauma. A lot of people actually go in the military because of family dysfunction. They want to get away from their small town. They don't all have families that are, loving families to go home to. So, you have a lot of people that come in, well, I don't know about a lot, but certainly we have some people that come into the military that have already been traumatized, and then they go into combat. Military PTS rates have been as high as 50%, but on average, it's around 15%. That's the most current data that I could find. Now, if you go back to Vietnam, the PTS rate is actually 30% for men and around, I believe it was 26% for women. So, we all people are exposed to trauma every single day, around the world, and most people do not get PTSD. So, okay, next slide, please. So this is just a nice slide. Actually, got this from the National Center for PTSD. And again, it corroborates that 15% rate of returning veterans from OIF, OEF. OIF is Operation Iraqi Freedom. OEF is Operation Enduring Freedom. So some people just, they have the depressive symptomatology, some anxiety, and then some with PTS. And then, of course, there's any of the three, you can see the rate is much higher. It's between 25 and 30%. So you think about, combat operations in Afghanistan started back in 2001. Combat ops began in Iraq in 2003. There have been around 2.5 to almost between 2.5 and 3 million American men and women that have been deployed since that time. Most people, not everybody stays in the military, obviously, but for some people do. It all depends. Many people, become injured and they have to get out. They'll have to, get a medical board on them. But not everybody follows up with the VA, interestingly enough. Everybody that serves in the military does have that opportunity to follow up with the Veterans Administration, but it's only around 40%. So the most, just for your own information, the most common reasons that people file claims with the VA is for musculoskeletal complaints. The second one is actually for, quote, mental disorders, and that is, PTS. And then there's a third category that are called ill-defined conditions, things that don't, just a smattering of this and that. So one thing I also want to mention real quickly, I alluded to it earlier when I talked about how many more people are surviving these days. If you're injured on the battlefield these days and you have a medevac helicopter that makes it in time to get you, your survival rate, the overall survival rate is around 95, 96%. So if you look at the people that have been killed in Iraq and Afghanistan, the number is relatively low, but the survival rate is much higher. Now, that's a double-edged sword, right? I've met more than a few guys that their injuries were so severe that I actually have had 2 or 3 people tell me that they wish they would have just been left to die on the battlefield. So they live, but oftentimes people have very, very poor quality of life. So, and then there's just debilitating injuries and chronic pain and very complex medical issues. So, okay, next slide, please. So we have the number of 15% that is post-traumatic stress reported, but we know that is vastly underreported. There's still a lot of shame, there's stigma, and in the military, especially with the Marines, it's the code is the motto is to keep going. It's you don't go to sick call, you suck it up, right? So the military really has done a fabulous job in publicizing PTSD. There's posters up all over the place at Marine units, Navy units. There's toll-free numbers. They're encouraged to seek treatment, and that's fine. But really, it comes down to the leadership. You can have that awareness, but if your sergeant, your gunnery sergeant is, standing there yelling at you in formation, telling you that only weaklings go to seek help for nightmares or any other symptoms, then it's not going to happen. So really, it does come down to a leadership thing. PTS is far more common in the civilian community than it is in the military, but again, the military has done such a good job publicizing it and getting the word out that you would think the only people that get PTSD are combat survivors, and that's definitely not the case. Okay, next slide, please. Okay, RAND, the RAND Corporation, that's a big think tank, and in DC, they did a fabulous study. It was back in 2008. You can actually access that online. I think it's 400 or 500 pages, but it is very, very in depth, and it came out with a lot of good information that is relevant to the conflicts that we've been engaged in since 9/11. But you look at that number of 50% or more having seen a friend seriously wounded or killed. That's an extraordinary number. Again, and then you can read the other stats. A lot of people see dead or wounded non-combatants. Almost 20% met the criteria for PTS or depression. But the thing that's not mentioned there is, oftentimes in cleanup operations overseas, there's actually Marines and sailors that are out there actually picking up body parts from people that might have been exposed to a mortar, a rocket, or an IED. So a common, the smell of decomposing bodies is, I think that's 40% of people report that, and those images of picking up your friend's, limb or whatever is something that's really is frequently cited as a big contributor to their PTS. People are not engaged in hand-to-hand combat quite as much today as we were back then. It's about 10%. And then, of course, some people witness brutality towards detainees or prisoners. That's a pretty low number. It's around 5%. When you think about how warfare has changed, I mean, back in World War II, the average amount of time that people spent in combat was about 40 days. Okay, Vietnam, it was around 250 days. And that was up close and personal in the jungle, fighting, bayoneting people, shooting people. These days with higher tech weapons, we have tomahawks, we have aircraft, we have drones. There's a tendency to, we don't just see quite as much hand-to-hand combat. Although, you think about Fallujah with the Marines, it certainly still does happen. So that is a really good study, and if you wanted to look that up, actually at the end of that study, they also identified there's several states that have programs in place for combat veterans to directly deal with PTS symptoms. I know Ohio was one of them. I can't remember the other ones, but you can actually Google that study, the RAND study, and get it online. It's outstanding. It's got a lot of good information in there. Okay, next slide, please. Okay, so the significance of all of this. We know that the people that go through the most intense combat scenarios are at higher risk for suicide, just because of the intensity of what they're going through and what they're seeing, what they're witnessing. Suicide risk factors. We know that people that younger enlisted people are at higher risk for that. You remember, there's a lot of people. I don't know what the average age is in the military, but when I was stationed with the Marines, I mean, these guys look like kids. They're 18, 19 years old. Brains are still developing until we're 24. So that that puts them at increased risk for suicide. Of course, prior mental health diagnosis. We'll talk about co-occurring stuff in just a minute. A big thing that they've really attributed increased risk of suicide is a lack of support. There's a lot of people that go over, unfortunately, that deploy overseas, and they'll get Dear John letters or Dear Jane letters. And, that's the one thing that many people have to look forward to. Again, I mean, the camaraderie is one thing, and you're with your friends, but, if you don't have a wife or you're a husband or a significant other to go through, that really takes the wind out of a lot of people's sails. And that really, that's really a huge risk factor. Marital and relationship, obviously, marital problems develop. Substance abuse is a big one. Alcohol primarily. The military these days have a zero tolerance policy on substance abuse. So even if you say you smoke some cannabis or do something and you pop positive on a urinalysis, you will be administratively separated. But oftentimes before that happens, they will offer the service member a chance for treatment, because we do have alcohol rehab centers and we have intensive outpatient programs all through the military. Of course, untreated PTS, again, we go back to that, talked a little bit about that earlier, and then of course childhood trauma. So those all are huge red flags. Okay, next slide, please. Okay, substance use again. So people that are coming back, it used to be in the old days, as far as alcohol goes, it was considered, it was acceptable at one point. Like when I first came in the Navy in 1982, it was considered acceptable to go over to the club at lunch and have a beer. I worked in a hospital, and go back to work. That was part of the culture. the culture has changed significantly now. So, alcohol-related, alcohol-oriented events have really been de-glamorized over the years because of the consistent problem. But, sailors will be sailors and Marines will be Marines. Soldiers will be soldiers. Even though people are underage, they're going to get their hands on alcohol. So, the one thing is, it used to be considered a career killer. It certainly is a career killer if you get a DUI, but if you self-refer for treatment, it's okay. It's not necessarily a career killer. So, the culture really has changed, and it does encourage people to seek help for alcohol. Higher risk for violence. I remember several years ago there was some real high-publicized cases in Fort Bragg where guys came back from combat, and I believe there was some infidelity or something on the part of their spouses, and this happened in 3 or 4 cases where these soldiers not only killed their wives, but they also killed the lovers of the wives, and they ultimately killed themselves. So people coming back from a high, combat, fast-paced environment can be problematic because, you come back from that sort of environment where you're literally trying to survive day to day, and then you come back and you have to go to the store to get a loaf of bread. So a lot of times people have difficulty in kind of putting the brakes on. I was actually had the good fortune to be stationed with a SEAL team a few years ago in Germany, and what some of the branches are certainly in special operations field is after people were coming out of theater in Iraq and Afghanistan, instead of going directly home, I know that many of them were being diverted to Germany, where Naval Special Warfare actually ended up paying for some time at a nice resort that had nothing to do with the military. It was in a place called Baden-Baden, which is a wonderful, beautiful German resort town, and the goal was to let them decompress. They brought in chaplains, they brought in counselors, and the goal was just to kind of slow down. That's really good in theory, and maybe some of the guys appreciated that, but again, it comes back to just one more delay from getting home, and there was more than a few people that were not too happy about that. And some people really got resentful about having to go to classes and speaking with chaplains or therapists or whoever that has no clue what it's like to be in combat. So there's a real big disconnect there, some distrust with civilians that just add fuel to the fire. And again, we know family dysfunction. We're going to talk about that a little bit more in just a second. And then the divorce rate amongst people, service members, is significantly higher than the civilian population. Okay, next slide, please. Okay, so co-occurring disorders. We know that the vast majority of people that have PTS have at least one co-occurring disorder, and this is really extremely important to be identified on the psychiatric evaluation or the assessment, physical examination. I am consistently amazed by how many people that I see here at Sierra Tucson that have been in treatment before for alcohol or substances, and I get to know them, and as I'm doing their psych eval, they tell me about their trauma history. And I say, well, you've been in 2 or 3 treatments before. Wasn't that addressed? And the answer is almost uniform. Those treatment centers don't do trauma. All they do is addiction. So it comes back to, trauma is the basement in the fire. If that is not dealt with, you're going to have a very low success rate with ongoing, treating the substance or, the trauma or whatever. So it's really, really important to identify those co-occurring disorders. And suicide is a big risk. Obviously, we always want to keep close tabs on that. Assess frequently. That's not a one-time question on initial assessment. Are you having any thoughts or plans? It's something that should be done on a consistent basis, not only by the physician but also by the therapy team. Okay, next slide, please. This is just want to talk a little bit about one of the common complaints that does happen with our vets is they have a lot of readjustment problems coming back. Again, we just talked about that a little bit, but as hard as some people try, they really just have difficulty finding their way back into society, and that usually will end up resulting in isolation. I remember when I got back from Iraq in 2004, it was difficult for me to go to a grocery store. You know, the most inane thing, like somebody bumping into me by accident would really, just really make me very, very irritable. So it takes time to come down from that. Another thing is when people get back, the unit typically speeds up, or not speeds up. It breaks up, and you had all this camaraderie on the battlefield, and all of a sudden people are going on leave. They're getting back with their families. So the single men and women have a tendency to feel, a little bit left out. So, and again, we talked just real briefly about the distrust with the non-military. Okay, next slide, please. Just real brief, we talk about maladaptive coping skills of people coming home. We know that substance use is probably at the top of the list, but there's other behaviors that can develop as well. Gambling and sexual compulsivity are two of them. Actually, compulsive sexual behavior is actually being studied much more closely, and it's found that that's actually really, really prevalent amongst veterans that are coming home from combat, and especially in those veterans that had a history of childhood trauma. Childhood trauma or any kind of sexual abuse. So if somebody has a diagnosis of PTS in the military, that's the compulsive sexual behavior should be something that's really looked at closely as well. Okay, next slide, please. Okay, we've been talking about the veterans, and the unsung hero of any successful guy or woman is their family back home. The family suffers as well as the veteran. There's a huge increase in domestic violence. The military actually has an active program in the Navy. It's called the Family Service Program, where all domestic violence or child abuse is taken very seriously, and there's a very good system put in place. Divorce, we talked about that earlier, but the impact on kids is something that's really interesting, because you have these little beings that don't really quite understand what's going on, and they very often develop social problems and behavior problems. Oftentimes kids can start wetting the bed. They can become real clingy with the parent that stayed behind. A lot of anxious attachment, maybe lower grades in school, fighting with their peers. Kids can't articulate themselves very well, depending upon their age, but a lot of them develop physical complaints like stomach aches and headaches. So fortunately, there are great resources for families. I think I mentioned the Family Service Center. I can't remember, but within the Navy and the Marine Corps, we have family service centers that have counselors and all kinds of resources available for the family. And there's also a fabulous website called Military One Source that has a plethora of family support options. Okay, next slide, please. Okay, so you have a combat veteran sitting in front of you who looks like he or she is pretty complex. Where do you begin? Well, I think every good assessment begins with a very, very solid psychiatric evaluation. You may not be doing the physical exam, but you certainly could inquire as if they have had one recently. There's a variety of screening tools available. Those are just a few of them. I know the PCL5 are very, very commonly used, but it can't be understated the importance of collateral information from the family, because you can have somebody sitting in front of you that is smiling and says, "I'm doing great," and then you talk to his wife and find out that he's beating her or abusing alcohol or whatever. Another thing is always ascertain whether there's any VA involvement. If somebody comes to you with PTS concerns, the Veterans Administration, we kind of have an incentivized system to be sick. People that have a PTSD diagnosis can get a certain amount of disability. So unfortunately, there have been numerous cases of people exaggerating and malingering out there. Next slide, please. Okay, as far as assessments go, VA recommends screening annually for the first 5 years, and then after that, once every 5 years. Remember, people's symptoms aren't necessarily going to show up right away. And it comes back to always assessing for self-harm and prior treatment history. Next slide. Differential diagnosis. So those are some of the most common psychiatric concerns that can also develop presenting as PTS. One that is not on there, I just want to mention, is traumatic brain injury. We can do a whole separate lecture on traumatic brain injury. There's so much information out there. Since 9/11, there have been around 362,000 people, I believe, that have suffered TBIs. Most of them are mild, most of them resolve spontaneously, but many of them don't. So people that develop with concentration problems, slowed thinking, irritability, anxiety, depression, you always want to inquire about if they've had a traumatic brain injury. Next slide, please. Okay, so treatment modalities. We know that medications can certainly help PTS symptoms, but they certainly are not curative. The bottom line is there's multiple different types of talk therapy that can be involved. Group, if you can get a guy in a group with other combat vets, that's fabulous. Anger management, and certainly marital counseling. First-line medications for anxiety are SSRIs. That's Prozac, Zoloft, Celexa, Lexapro, medications like that. Benzodiazepines are not recommended in use in treating post-traumatic stress. Yet I'm consistently surprised at how many people are on benzos, and those are Xanax, Klonopin, Valium, meds like that. In a perfect world, benzos would be prescribed for 2 to 4 weeks. So just remember, first-line treatment medication-wise is SSRIs. Okay, next slide, please. Okay, so treatment modalities. One of the great things I love about being here at Sierra is we are integrative, and we know that people have the greatest success with a variety of treatments. You can read them there, everything from EMDR to equine, exercise, meditation, yoga. TMS is something, transcranial magnetic stimulation, that has been shown to be promising off-label. It's FDA approved for treating depression, but it is being used for PTS as well. Next slide, please. Okay, so healthcare provider role, pretty straightforward. We want to screen, get that good history. That's the most important thing. Treat what we can, treat what we're comfortable with. If you are fortunate enough to have a VA in your area, then they are a fabulous resource. I know that the VA has gotten a lot of bad press over the years. I think that they're doing the best with what they have, and they do have a lot of PTS-specific programs around the country. Certainly, residential treatment facilities. We see combat veterans here on a regular basis, and then getting some of your vets hooked up with veterans organizations it comes back to that camaraderie, and again, feeling like you belong. Okay, next slide. Okay, this is the last slide. That's actually a picture over on the right. That's me and 2 of my buddies. That was the day that we left Iraq, and I got to tell you, that was that was one of the happiest days of my life. And we certainly had gone through a lot, but it was an honor and a privilege to take care of Marines. I just want to mention this case study real quick. We had a guy here a couple of months ago who was not in the military, but he actually was born in Afghanistan, and he moved with his family here at a very young age. He's an American citizen, but he got assigned with a defense contracting company to go over and work with special forces in Afghanistan as an interpreter. Well, this guy went back 2 or 3 times, ultimately was diagnosed with PTS, but he came to us in a pretty severe, moderate to severe state with frequent dissociation. But his biggest complaint is that because he was not in the military, he could not get in with the VA. He could not find any of that camaraderie that is so important to people, and it was a very, very frustrating. Trying to find him continuing care because of, bottom line is he wasn't in the military, and that unfortunately did not make him eligible for the VA. So, okay, next slide. Okay, and that is it. I know that's a lot of information, and, I hope you were able to get something out of that. There's my contact information. If anybody has any questions or wants to call me, I'd be happy to talk with you. And now we have time for some questions. Thank you very much. I appreciate your attention.
Great. Thanks so much, Bill. We'd like to remind everyone in our audience that you can use that Q&A area below the slides to submit a question if you wish. Also, to download a copy of the slides, please click on the link in the Resources tab to the right of the presentation window. So someone in our audience is asking about the use of virtual reality. Do you have any thoughts on this treatment modality?
Oh, that is an excellent question. I actually had meant to put that in there. Actually, I think the University of Southern California is doing some really, really exciting stuff with VR, specifically tailored for combat vets. I forgot to obviously include that in my presentation. And I also know at Walter Reed, I know that Walter Reed is, that's back in the D.C. area. It's an Army Navy hospital. They're using a program, I believe it's called Battlefield or Battle Mine or something, where it's kind of an exposure therapy. So they are doing that within the military to some degree. But the stuff at USC sounded like it was very, very promising. So yes, thank you.
Okay, great. And someone in our audience is asking about veterans who might be in the prison system. Do you know anything about best practice treatment for them, or if they're even getting treatment?
Oh, that is a good question. I don't know, to be honest with you. That is obviously a very specialized population. I know that within the prison system. Well, I know we have services for they have AA and they certainly have support groups like that. But as far as programs specific for PTS and combat, I do not know. Very good question. I'm sorry, I can't answer that.
Okay, and someone in our audience is asking about follow-up. What type of aftercare would you recommend after individuals have completed treatment?
For people that remain in the military, there's people that go initially through sort of an intensive course of treatment. I mean, again, everybody's different, but there are many people in the military that continue to follow up with their psychologist or their psychiatrist on a regular basis. Even for EMDR, I know that we've been using EMDR for a very, very long time in the military. So I think that's individualized to the service member. Many people are started on SSRI medications like Paxil, Prozac, which I mentioned earlier, and it's okay to remain on those, except there's certain circumstances like in the submarines. I think in special warfare you can't be on that, but yeah, so that's going to be dictated. The follow-up will be dictated by their care provider. For people that are of a more serious nature and really just can't return to duty, then they would undergo what's called a medical board, and they would be medically ultimately put out of the service because of that, what we call disability. Thank you.
Okay, and another question for you. And the question is about the correlation between PTS and sexual addiction or use of pornography. Is there any information that you might have about the relationship between those two?
Not off the top of my head. I did a little bit of research. There was actually a study that was done. It's a relatively small study within the past maybe year or two, but I recall reading something about that. Let me see. This was actually in the Journal of Behavioral Addiction from 2014. The study stated that compulsive sexual behavior is prevalent amongst veterans returning from combat, and nearly all of those with compulsive sexual behavior had a PTSD diagnosis at baseline, and there was a significant and positive association between PTSD severity and compulsive sexual behavior after adjusting for covariates. So again, that came from the Journal of Behavioral Addiction in 2014. Perhaps there's something more current out there. Thank you.
Okay, an audience member is asking, what would you say to a family member of a vet with PTS? What are some of the recommendations that you would have for them?
I think for family members, it's really education is key. You could do that certainly as a therapist or as a healthcare provider to some degree. I know a lot of people get involved with NAMI, the National Alliance for the Mentally Ill. They have They have programs, for a variety of mental health conditions, to include post-traumatic stress. I'm sure that the VA probably has some really healthy family programs out there as well. A lot of very, very good information. If you Google this, maybe some of you are familiar with it, but we have a national center for PTSD that was started by the VA a few years ago, and it has got a plethora of information to include handouts for family members, educational videos, and also lists, VA facilities where perhaps I'm sure they have support groups for family members. But to answer your question, I think education is the key, and just encouraging them to be patient and just making them aware that what their veteran may be experiencing is, quote, normal for what they've been through. Thank you.
Well, that's good advice. And you had mentioned earlier recommending that benzodiazepines not be used for more than 2 to 4 weeks. And what is your reasoning for saying that?
With benzodiazepines, there is a huge risk for physical and psychological dependence on those meds. Those medications work great, but really within the mental health field, within psychiatry, the long-term use is simply not recommended, especially in somebody that is struggling with alcohol. There are huge rates of cross-addiction between that. There have been multiple deaths reported with people drinking large amounts of alcohol and taking benzos. And it's also showing, there's more recent literature that the long-term use of those meds can result in some cognitive problems. There's been reports of some people developing early dementia. Benzos are easy to get. You can get them from your primary care doc, and I'm really continually shocked by the amount of benzos that some people come into treatment here on. And people generally do not want to give up their benzos. Ultimately, they're going to need more and more and more, and they're just going to develop that tolerance. So what we really try to focus on here is the SSRIs, and there's other safer medications to use besides benzos. It's just they're fraught with problems, beyond addiction. Thank you.
Now, you had mentioned earlier the difference in risk for PTS between men and women. Do you know if age or if the amount of time in the military affects a person's risk for PTS?
I know that the younger people are at higher risk, and I think as far as time in the military, I think that depends upon what they're doing. If you have somebody that's on an aircraft carrier and doesn't set foot in Afghanistan, they're less likely to experience that. But just remember that the Army has had some people sometimes do have their troops do 15 months in theater. At least being with the Marines are always really good about keeping deployments to 6 to 7 months. But I just think it depends upon what their job title is. We know that the younger the person, more likely to be enlisted, prior trauma. That's the greatest risk. But I think the time in the military is less important than what they experience.
All right, let's finish up with one quick one. Do you know, are military units doing any prevention programs prior to deployment?
Yes, they are. Before anybody deploys in theater, many, at least I know within the Navy, they've started classes on resilience, just kind of educational programs, what to expect. They do the same thing within the Marine Corps, to the best of my knowledge, at least they used to. And the military has also been very good about tracking post-traumatic PTS symptoms. So before anybody deploys, they do what's called a pre-deployment health risk assessment, which identifies, current symptoms they may be having. And then whenever anybody leaves, when they come home, they also do what's called a post-deployment health assessment. So the data is being tracked, and the people that, kind of raise red flags with the responses to their questions are identified as people touch base with them and check in and see that they get help. Okay.
Well, that's definitely encouraging. Unfortunately, that is all the time that we have for questions today. Please remember the instructions regarding CE credit. Do not close your window. Please continue to stay on the platform, and the site will automatically redirect you to a survey. This survey must be completed in order to generate your CE certificate. For those watching in a group, as a reminder, please download the group submission guide in the Resources tab, which is to the right of your slides, and follow the instructions provided. Also note that CE credit is not available for the archived webinar. It's only available for the live event on September 13th, 2017. And I would like to thank Bill Reynolds once again for sharing his insight. I would also like to thank our sponsor, Sierra Tucson, for making today's program possible. Finally, thank you to everyone in our audience for participating today. We do hope you'll join us again in the future for another Addiction Professional webinar. This concludes today's presentation.